Okay. Hi, everyone. My name is Stephanie Gopaul. I'm PGY3. The title of my lecture is The Impact of COVID-19 on Health Disparities as part of the Social EM Medicine lecture series. So just a quick agenda. Specifically, I'll be talking about racial and ethnic disparities in COVID-19. We'll talk about some of the contributors to these health disparities. A special mention of some specific populations, undocumented immigrants, our incarcerated population, our houseless or homeless population. We'll talk a bit about the CARES Act funding and distribution of the funding, some barriers to the COVID vaccine, and then some potential healthcare solutions. So on March 31st, 2020, at the height of the pandemic, Governor Cuomo called COVID vaccine the great equalizer. And there was sort of this movement that, we were New York strong and we were all in this together. However, as the pandemic progressed, it turns out we had some theories about who might be most affected by COVID, right? You might imagine that people with underlying medical comorbidities or a geriatric population might be more susceptible and have higher mortality due to COVID-19. However, as the pandemic progressed, what we saw is that racial minorities tended to comprise a greater disproportion of COVID-19 cases as well as deaths. This was not necessarily expected. So just some data that supports that. This is data from the COVID Tracking project. This is a collaboration between the Atlantic and the Boston Center for Anti-Racist Research. And just a note about data collection. So early on in the pandemic, COVID truly overwhelmed our public health systems, and a lot of demographic data was not collected early on. This is data from 51 states. And you can see, so I'm going to try to just bring my mouse over, but in the United States up until January 16th, national data. On the left, you can see cases per 100,000 people by, can you hear me? Sorry, by racial category, and then deaths per 100,000 people by racial category. And in terms of cases are highest among Native Hawaiian, Pacific Islander racial population, followed by American Indian, Alaska Native, followed by Hispanic population, followed by Black population, white, and then Asian. However, in terms of deaths, deaths by COVID-19 are highest among the Black population, followed by American Indian, Alaska Native, followed by the Hispanic Latino population, and then Native Hawaiian, then white and Asian. Who is dying? Nationwide, Black people are dying at 1.5 times the rate of white people. This is followed closely by American Indian or Alaska Native grouped together, dying at 1.4 times the rate of white people. In New York specifically, the COVID Tracking project, their website, they have this data broken down by state. Specifically, they have reported race ethnicity data for 87% of deaths in New York State. And the way that they report disparity, they actually look at the percentage of death as a proportion of utilizing the census data. And then they determine if a disparity exists if the proportion of death is at least 33% higher than the census percent of the population. If it remains elevated, whether they include or exclude cases and deaths where race or ethnicity is unknown. And if it's based on at least 30 actual cases or deaths. So if you sort of look at where I circled, you see in New York, Black people make up 14% of the population, yet they account for 24% of deaths in New York. So based on that, a likely health disparity exists in that Black people are accounting for a disproportionate number of COVID-19 deaths here in New York State. This is some data from the Commonwealth Foundation. So I mentioned early on in the pandemic, we weren't really great about collecting demographic data. So what some other people did was they looked at COVID-19 mortality based at the county level. This is because in the US, we actually live in highly racially segregated communities, and certain counties have higher proportions of Black residents. So what they did was they looked at COVID-19 mortalities in communities that had higher percentages of the Black population. So this is a study from the Commonwealth Fund. Sorry, I'm just gonna put my mouse back. From the Commonwealth Fund. And what they did was they looked at counties with high concentrations of Black populations versus counties with low concentrations of Black population. And a high concentration was defined as a population of greater than 13.4%, which is greater than the nationwide Black population, which is 13%. And you can see on the left, this is looking at the confirmed COVID-19 cases. And in the green, this is counties that have higher than average Black race compared to the gray, which is counties that have lower than average Black race. And you can see that COVID-19 cases are on average higher in counties that have higher than average Black race. In the graph on the right, they're looking at death from COVID-19 cases, and in the orange, these are counties with higher than average Black race. In the gray, counties with lower than average Black race. And you can see that COVID-19 deaths are higher in the counties that have a higher than average Black race. And this has actually been reproduced in several other studies. This is just an example of one. And then just to sort of drive the point home, this is a CDC national data that also demonstrates that ethnic minorities are overrepresented in terms of COVID deaths. This shows the age-adjusted percent of COVID-19 deaths against the population distribution by race. So the red is the distribution of COVID-19 deaths, and then the purple is the unweighted distribution of the population. On the bottom, you can see the race. So the first column being non-Hispanic white people, so just white people. And then you see the red is the distribution of COVID deaths, and you see the proportion of COVID deaths is much smaller for white people than the distribution of the population. However, when I highlighted sort of, or the little stars indicate racial and ethnic minority population. So Hispanic people, Black people, American Indian, Alaska Native, Native Hawaiian, and then Pacific Islander people. You see for these groups, the percent of COVID deaths is much higher than the percent of these populations within the total US population. Again, demonstrating that there's likely some disparity in these people. These groups are dying at higher rates from COVID-19. So was this predictable? For many people, yes. Health disparities experts, and especially people who are working on the front lines, they anticipated that COVID-19 would likely result in worsening racial health disparities. The virus was rapidly spreading through dense urban communities, and this is primarily where racial minorities tend to live. Additionally, these communities were already being plagued with poverty, a lot of job and economic insecurity, lack of educational opportunities. And so many people who are already familiar with this type of work predicted that these communities would be impacted heavily by COVID. So in addition to sort of some of the underlying social determinants of health that we know contributed to COVID-19, I just wanted to talk about some more specific factors. So one being sort of an increased chronic disease burden within minority communities. We know that African Americans and Latinx communities in particular have higher rates of diabetes, hypertension, obesity, stroke, heart disease, and cancer compared to white people. However, I want to point out that again, this increased chronic disease burden really does represent broader socioeconomic disparities, not innate biological differences, right? They're driven by differences in access to care, differences in education, financial status, social status, and immigration. They're also driven by differences in access to health insurance, right? African Americans and Latinx individuals are less likely to be uninsured and underinsured. This also has implications for COVID. Because when people become sick with COVID, especially if they become severely ill and have to become hospitalized, there are implications in terms of how they pay their bills. If they become unemployed and lose their employee-sponsored health insurance, they suffer job loss, further financial ruin. And then if there are any long-term sequelae of COVID-19, we don't know, right? And we don't know what the long-term health outcomes of this will be. And in people who are already chronically ill or are chronically uninsured, and have long-term sequelae, they likely will have worse outcomes down the line. And then a little bit of some cultural barriers that came up early on. One would be sort of quarantine barriers. And I can just point you to this article that was published by Dr. Garth Walker. He's a ED physician in Chicago. But this article, what he states: as a doctor, how do I tell a Black family of 5 struck by the virus to social distance in a 2-bedroom apartment? I think this is something that we can all relate to here with our patients in New York City, where apartments are very small and dense and expensive. And it just is difficult to tell people to quarantine. So I think we say that, right? We say you probably have COVID and you should go home and quarantine. But that is just not realistic for a lot of people. People have to live in shared spaces for a multitude of reasons. That can be cultural. A lot of our immigrant families live in multi-generational homes for cultural reasons, but also as a cost-saving mechanism. New York City apartments are expensive and small, and so people can only afford to live in shared spaces. And then mask wearing not being safe in some communities. This was a huge recommendation early on, and a lot of people, Black men in particular, expressed a lot of unease at wearing masks. They were concerned that it would make them a target, especially a target by NYPD for police brutality, or people would see them and think they were criminals and call the police on them. And so a lot of Black men definitely felt that they were making the decision between being exposed to the coronavirus or becoming a target for abuse by police. Another issue was utilization of public and mass transit. So using the subways or the bus systems in New York is a low cost, convenient form of transportation. When coronavirus hit, people who are wealthy, right, had the option to rent those motorized scooters or rent an Uber or pay for a rental car, right? Poor people cannot do that. They have to continue to get on the subways. They have to continue to expose themselves to coronavirus. And that definitely led to increased risk for these people. And then finally, the need to work. Again, people who have money can afford to take time off of work and directly reduce their risk and exposure to coronavirus. Poor people don't have savings. They don't have rainy day funds and the ability to take time off of work. They had to go to work and be exposed to coronavirus. And then finally, there's definitely an overrepresentation of minorities in essential work. This is a statistic from 2018 from the U.S. Bureau of Labor Statistics, but 49% of Hispanic and Black workers are employed in the service industry compared to 16% of white workers. And this is still the case, but and this is for a multitude of reasons, but Black and Hispanic people are overrepresented in frontline work and are overrepresented in frontline work and in essential work, and that directly increases their risk and their exposure to COVID-19. So basically, COVID-19, what it did was it shined a light on existing systemic racism. This schematic is an overview of the various levels of racism and how society fosters discrimination through mutually reinforcing inequitable systems. These systems range from discriminatory lending and banking systems to geographical redlining in the housing, to disparate sentencing in the criminal justice system. They've always been there. They've existed for centuries. But really what COVID-19 did was shine a light. And next, I'm just going to talk about some specific vulnerable populations. Oops, sorry, I think Taylor told me the mouse is in the way. Vulnerable populations, including our houseless or homeless populations, prisoners and undocumented immigrants. So our houseless populations, I'm sure some of you know this, but they are suffering even more than other New Yorkers. This is data from the New York City Coalition for the Homeless. And it shows that the mortality for our sheltered population in New York City is 61% higher compared to all other New Yorkers. So this, sorry, go back again. This line in, it's a little hard to see. So this is the crude rate for the homeless mortality. And then this is the age-adjusted rate for our homeless mortality, and this is the all New York City mortality rate. So you see when you do like the age-adjusted rate, our homeless patients have a higher mortality, and you can imagine why that is. They also had a higher infection rate of COVID-19. This is due to sort of the shared communal spaces that our homeless populations have. And early on in the pandemic, there were limited efforts made to socially distance them or isolate them, and so COVID-19 spread. And at baseline, our homeless population have higher rates of chronic diseases. They have a lower functional status. They have low social support, and so this resulted in increased mortality. And then Black and Latinx individuals are disproportionately affected by homelessness. 42% of our homeless population is Black, 34% of our homeless population is Hispanic. So that's about 70% of our homeless population is represented by minorities. So again, Black and Latinx individuals are disproportionately affected by both homelessness and by COVID-19 here in New York. Just a word about the incarcerated population in COVID-19. The US is currently #1 in two things. We are #1 in the number of COVID-19 deaths, and we are #1 in the number of incarcerated people in the world. We have the largest incarcerated population in the world, and we are especially good at incarcerating Black men. 1 in every 15 Black males over the age of 18 is incarcerated in the US. It's an incredible statistic. And Black people are disproportionately incarcerated due to systemic racism. Similar to the homeless population, COVID-19 has just spread through the prison system because of shared communal spaces and very poor efforts to limit the spread early in the pandemic. COVID-19 cases are 5.5 times higher among incarcerated people. Unfortunately, incarcerated people and houseless people don't have much political pull. They don't have much societal favor. And because of that, many human rights abuses among these groups go unnoticed. There are some efforts to try to help reduce the spread of COVID-19 among the prison population. One is vaccination, which I'll talk about a little bit later. And the other is decarceration, which are efforts to directly reduce the incarcerated population. This is through a variety of means, things like issuing citations in lieu of arrest, early release for people who are immunocompromised or who have committed nonviolent offenses, early release for people who are up for parole. And these are being done in some states, not in New York. And importantly, decarceration has been shown to not increase crime rates. And then undocumented immigrants in COVID-19. I apologize, this is a little bit of a busy slide, but it's sort of more of the same. We have a large undocumented immigrant population, here in Brooklyn, but undocumented immigrants have several of the same medical concerns in medical issues in terms of being underinsured and uninsured, thus limiting their access to medical care. They tend to have increased job insecurity and economic insecurity. They have the additional problem of legal issues, right? They tend to be concerned about deportation, and this may increase their hesitancy to seek medical care. And then they also have some social risk factors in terms of language barriers. This can inhibit their ability to get crucial public health information about how to protect themselves from COVID, or where to seek accurate public health information. And I should also mention that undocumented immigrants did not qualify for any type of government aid at all. Even if they had children, some of the CARES Act funding, people got money individually, but then you could also get money you got like $500, I think, for each of your kids. Even if you were undocumented and you had children that were born in the US, you still didn't get money for any of your children. So just an overview of CARES funding. So CARES stands for Coronavirus Aid, Relief, and Economic Security Act. This was signed by President Trump on March 27th, 2020. Again, this is just a big overview of all the funding. It's a huge bill, $900 billion. I'm going to focus on the $73 billion that was sent to healthcare. I apologize. I was going to talk a little bit about the small business part, but I'm going to take that out because I don't think I'm going to have time. But the healthcare part, these were direct, part of this was direct payments made to hospitals. And that's the part that I'm going to focus on. So in terms of these allocations that were made to hospitals, they were made in 3 phases of payments. And the way that Congress determined these payments to the hospitals, the first 2 phases of payments, allocations, were made based on each hospital's Medicare fee-for-service revenue and their total patient revenue. So hospitals that generated larger revenues qualified for larger relief packages. The 3rd phase of payments were allocated based on expenses or the hospital's reported lost revenue. So hospitals with larger operating revenues could petition for larger lost revenue and again have larger relief packages. Hospitals that generate larger revenues tend to have patients who are privately insured. They tend to have patients who have employer-sponsored health insurance plans. They tend to have patients who are on Medicare. And this is because hospital revenue is mainly determined by 2 factors, patient volume and then also payment rates per service. And these payment rates can vary widely and they're often determined by payer type. So private insurance, for instance, typically reimburses way better than Medicare, right? It reimburses at twice the rate of Medicare. So if you have a high number of privately insured patients, you're gonna have a higher patient revenue. And by this algorithm that Congress used, you likely are going to get more relief. So the Kaiser Family Foundation did this very interesting analysis. They looked at the allocation of CARES funding using data from the Center for Medicare and Medicaid Services based on the percent of private insurance patients that a hospital had. They conducted an analysis of hospitals, hospitals that had the highest and lowest shares of revenue from private insurers. So hospitals, the 10% of hospitals that had the highest share of revenue from private insurance and the 10% of hospitals that had the lowest share of revenue from private insurers. And they found that the formula that Congress used ended up favoring hospitals with the highest share of private insurance revenue as a percent of their total patient revenues. So specifically in the chart on the left, if you look, the hospitals with the highest share of private insurance revenue ended up generating $44,000 per patient bed, whereas hospitals with the lowest share of private insurance revenue ended up receiving about $20,000 per patient bed. They also looked at some of the characteristics of these hospitals, and they saw that hospitals that had a higher share of private insurance revenue tended more so to be for-profit hospitals and were less likely to be teaching hospitals. All in all, these hospitals that had more private hospitals with more private insurance and had larger operating revenues. They also had provided less uncompensated care. So this was care to undocumented people, charity care, and these were the hospitals that received more CARES relief. So knowing how Congress decided to do this disbursement, I want you to think about how this might have played out at our hospital systems here in New York City. And while you're thinking about that, I just will try to very briefly go over sort of our hospital systems here in New York. Basically, over the past few years, this is just a very brief summary, but over the past few years, healthcare in New York City has sort of been consolidated such that we have like 5 major private healthcare networks in New York City: Mount Sinai, NYU Langone, Montefiore, New York Presbyterian, and Northwell Health. These are generally citywide. They're wealthy nonprofit hospital systems. They have large revenue, And this is because most of their patients are privately insured or on Medicare. Then you have a large public hospital system. So this is NYC H&H. This is us. This is comprised of 11 public hospital systems. There are a few like smaller independent hospitals, some private community hospitals which are struggling, and like safety net hospitals. There's a huge inequity between these two hospital systems. This is apparent in the net operating revenue and the depth of the financial reserves of these two hospital systems. Most public and community hospitals are operating on deficits. The big five networks have large revenues and financial reserves. Specifically, the big five have a combined operating revenue of $877 million. NYC H&H actually up until pretty recently had been operating with a $3 billion deficit. They underwent this really great restructuring in 2016, and now we are doing like pretty great, $36 million positive, operating, well, now we have a $36 million revenue. Yeah, that's the word I want to say. But the restructuring in 2016 is interesting. They talk about the fact that NYC, because we provide so much of the uncompensated care, right? We provide so much of the care for people who do not have health insurance, for people who are undocumented, for people who have mental health issues, for people who have substance abuse. Because we provide so much of that care, we have directly contributed to the growing wealth of these other hospital systems. And they actually say that in this restructuring report. And so this has just really contributed to these two very inequitable hospital systems that we have here in New York. And so based on this, you might imagine how the CARES distribution money played out. And so we have these numbers, they're available. It's publicly available data on the CDC website. This was actually dispersed into, the money came out in two separate disbursements. I combined them just for like simplicity's sake, but I have them presented in descending order. So on the left side of the screen, you can see that the company that got the most money was Long Island Jewish Medical Center, or Northwell, at $277 million. And then going down from there, it's NYU, right, at $203 million. Then there's Monty, then there's Columbia. So on the left side of the screen, I think there's 13 hospitals there, right? There's NYC H&H Elmhurst with $113 million, and then Bronx Care, which is formerly Bronx Lebanon, with $91 million. That's it. The others there are all the big five. Everyone on that screen is all the big five. It's all NYP, it's all Montefiore, it's all NYU. If you look on the right side of the screen, then we start to see Kings County at $78.9 million. And then we see SUNY Downstate, which was our designated COVID center, at $47 million. And SUNY Downstate, interestingly, only got one round of payouts. Unclear why, I'm not sure, but they only got one round of payouts. And then I just want to highlight, in gray, I highlighted some smaller hospitals in the area, like Brookdale, Brooklyn Hospital Center, Kingsbrook, and Interfaith. So these are some of our smaller independent hospitals, although Interfaith, Kingsbrook, and Brooklyn Hospital are all part of like the One Brooklyn Health Center, but they provide a care to an underserved population. We know this, a lot of our patients go to these hospitals as well, but these are also struggling hospital systems as well. And you can see they also received very, very minimal funding from the CARES Act as well. I just wanted to touch on this briefly. I decided to add it in, just a point about vaccination, because this is coming up too, and just some barriers to vaccination. So one, barriers to vaccination, we have limited vaccines. I think we all know this. Every week we're getting like updates from Governor Cuomo how we don't have enough vaccines. And so that's a barrier in and of itself. But then there are also issues with logistics of the vaccination. I don't know if any of you have seen the vaccination website. It's not super user friendly. The vaccine, there are no appointments available. So for you to actually get an appointment, you have to constantly be online and checking to get a vaccine. So really, if you like don't have access to a computer, don't have access to a stable internet connection, you really cannot and you're like a young person who knows how to use it, you can't really make an appointment. So people who are uninsured or who lack access to all those things that I just mentioned. Finally, there are a lot of difficulties with reaching underserved communities for these reasons. New York has created a New York Vaccine Equity Task Force to help address some of these issues. And they have made some efforts. For example, they have set up some pop-up vaccination shops at senior housing developments, specifically the William Reed houses, and I think the Vandalia apartment housing complexes, which are primarily minority senior housing developments, to help deal with this issue. So it's an effort, it's a step in the right direction, but it is, Adrian is saying, the vaccination sign-up website is a major barrier to access. It absolutely is. But it is a huge barrier. And another issue is distrust of the medical community. This is going to be a huge issue that we are going to have to try to fix. Distrust of the medical community and of the vaccination is totally warranted in the minority community. The medical community has committed very serious human rights abuses historical abuses against people of color. And they have every right to be distrustful of the medical community. And we have significant work to do to repair that relationship. And then finally, there's absolutely no inclusion of prisoners in our plans to vaccinate. Like, we don't even mention them. There are 3 phases of who we vaccinate, and there's like no mention of prisoners at all in the New York City plan. Some other states have made mention of it. Some states have included them in the initial vaccination plan. New York has not talked about it at all. So again, they are completely left out. And then some healthcare solutions that I just wanted to talk about. Sorry, I know a lot of this can be sort of overwhelming and you're like, what can I do to help? Some things that I think you can do as an ED provider, like 1, take a social history, especially when you're dealing with COVID-19 in your patients. When you're thinking about giving people quarantine instructions, really assess if they can quarantine. What I've discovered is that even the COVID hotels, for example, they're not just available for patients who are homeless. I had like a 20-year-old who lived with her grandma who are referred to social work, and then they were able to put her into a hotel for 10 days. So she did not give her grandma COVID, which was great. So find out if they truly can socially distance and if they have the means to do so. Also, assess if they are having other social barriers, right? Like, did they lose their job because of COVID? Are they now experiencing food insecurity because of COVID? Different things like that, and then refer them appropriately. People, like I said, people are experiencing like significant difficulty now with COVID-19, and I think it's up to us to really do our due diligence and go the extra mile and ask those questions. And that goes along with knowing your community's resources. We don't have to know an exhaustive list, right? But we should know some of those resources and be able to refer people. And then just a side note of practicing cultural humility in all of our patient interactions. Some short-term, more broader solutions to COVID-19. We're doing this. We're offering free COVID-19 testing. We're supposed to be offering affordable care for all patients with COVID-19. There are isolated events of people receiving bills and things like that. But in theory, COVID-19 treatment should be affordable for all people. We need to do better in terms of targeting resources to minority and underserved communities. This should be done via community partnerships that are well established in communities of color, and have pre-existing relationships with these communities. And then finally, there needs to be sort of a shared demand. I actually think this is a really interesting concept. There's a really great paper. It was published in Health Affairs. It has to do with the inter-facility transfer that was sort of developed here during COVID. I think Dr. Budarakis and maybe Dr. Salway published a paper in Health Affairs on this. But it was basically this process where we do level loading and we transfer patients between facilities based on demand. And it was a way of dealing with our hospitals becoming inundated with COVID patients at the height of the pandemic. And in the paper, they talk about how if we can expand this sort of process to hospitals outside of H&H, it can really sort of help deal with distributing our resources in a better way. Of course, that's not really possible with the way our healthcare system is so fragmented in New York, but that would be great to do if we had a sort of a more cohesive healthcare system, because we really could could share our resources in a better way and could divert resources to places that really need it. And then finally, short term, again, I said develop quarantine protocols. I talked about this a little bit, but ensuring that we have realistic quarantine protocols for people. And then continuing to collect demographic data for COVID-19. We don't know that disparities exist if we don't collect this data, so we should. More long-term solutions. This is a marathon and not a sprint. So this is going to be requiring us to dismantle structural racism at all levels. With regard to health, this is going to require us to advocate for policies that address the social determinants of health. I think this will be electing representatives that support policies that dismantle systems of racial oppression. For some of you, hopefully that means entering into elected positions and things like that. For me, it means advocating for single payer healthcare. Our current healthcare system is unsustainable, and it's unfortunately one that results in and perpetuates health disparities. The thing about COVID is as terrible as it has been. I think it has created a lot of civil unrest, and it has thrust the topic of health disparities back into the public consciousness. And so I think it has created an opportunity to advance policies that address the social determinants of health and hopefully create a more equitable society. I think that's it. And if you guys have any questions, I'm happy to answer. Thanks.
Thank you, Stephanie. A lot of information, a lot of stuff covered. Couldn't agree more. COVID is kind of just shining a light on. I think the biggest thing for us, like you said, is there are some resources that we can use, but I think the biggest thing we have to do is ask. We have to talk to patients and see what they need. So if we don't ask, a lot of times it's not going to come. So I think that's one of the biggest takeaways.
Yeah, definitely. And I think I didn't know that the COVID hotels were available just to patients who were not homeless. That was actually a surprise. I didn't figure that out. Social work actually came up to me and was like, we can do this. And I was like, oh my gosh. So yeah, if you think a person, I give all credit goes to social work. They were the one who prompted me to think of that.
It's been amazing.
Yeah.
There's such a huge help. And like you said, it's impossible for us to know all the resources available.
Yeah.
There's such an amazing resource.
I'm just going to quickly read the chat. Sorry, I don't know if anybody.
They were mainly talking about their chart. And then Adrian saying, just remember about the food boxes and now how, which is now epic for us to use.
Yeah, I forgot to mention that. I think it's a good idea. I know you guys have a million things to do, but it's worth it if you have a few seconds to familiarize yourself with NowPow, just in case. It's not like the hardest thing to do, and you can always print out resources and give them to your patients if you feel up to it. All right, thanks guys.